cardiologist, and this is moderated by Jennifer from GE Healthcare. We have tried to select relevant topics in line with the 2021 World Heart Day theme. So let me have the pleasure of introducing the panelists and the moderator. So Dr. Praveer Sinha is the renowned cardiologist from Darbhanga, Bihar, uh, ranked first during his final professional exam. He has been practicing at Darbhanga since 1997 as a consultant cardiologist, has got his own cardiology setup, and his special interest lies in echocardiography. He is a member of CSI, API, ICC, and formerly of ESC, organizing secretary of CSI Bihar Chapter 2019, presented and deliberated various topics in cardiology and related comorbid diseases at various national and state level scientific conferences. He is actively associated as speaker and moderator with AstraZeneca, BI, Lupin, Abbott, Sun Pharma, and others. Welcome, Dr. Praveer Sinha.
Thank you.
We have Dr. Rahul Mehrotra, MBBS Gold Medalist, MD Medicine, DNB Cardiology. He is currently the Director and the Head of Non-Invasive Cardiology, Max Super Specialty Hospital, Saket, New Delhi. Dr. Rahul has been consultant with some of the leading corporate hospitals in and around Delhi for a while. He has conducted more than 94 workshops and lecture presentations. He is life member of CSI and Indian Academy of Echocardiography. He has been a merit student from his 10th and has won several scholarships, award, and gold medals. He is a recipient of Dr. M. Chenna Reddy Award and Gold Medal in Cardiology, presented by Honorable Vice President of India for Best Research Paper at Rajapikon in 2001. He has got several research and publications, 14 original research articles, 14 review articles, 20 chapters in books, and miscellaneous publications around 7 numbers. Welcome, Dr. Rahul Mehrotra. Next in the panel, we have Dr. Ullas Pandurangi, MD DM. Currently, Dr. Ullas is the Chief Cardiac Electrophysiology and Pacing, Institute of Cardiovascular Diseases, Arrhythmia Heart Failure Academy, Madras Medical Mission, Chennai. He is the Vice President, Indian Heart Rhythm Society. He is the founder of Tamil Nadu Electrophysiology Council. He has been past president, Indian Society of Electrocardiology. He has been the recipient of Dr. B.P. Basu Award in 2002. He is also awarded Young Cardiologist at CSI Conference in 1997 and Best Doctor Award from Tamil Nadu Dr. MGR Medical University in 2013. Welcome, Dr. Ullas Pandurangi, sir. And last but not the least, we have Dr. Ashish Nabha, MD, DNB, PhD Cardiac Electrophysiology, Board Certified Cardiologist, the Netherlands. Dr. Ashish is currently the consultant cardiologist and electrophysiologist at Jupiter Hospital, Thane, and Leelavati Hospital, Mumbai. He is also visiting consultant at Department of Cardiology, KEM Hospital, Mumbai. He is the Executive Council member, Indian Heart Rhythm Society, Joint Secretary, Executive Council member, Indian Society of Electrocardiology, is the treasurer. Some of his achievements is he is first in the country to be awarded PhD in cardiac electrophysiology. He's got a 25 years vast years of enriched experience in the field of cardiology. Proficiency in routine and complex RF ablations and cardiac implantable electrical device implants and redo procedures. He has published and presented extensively in international and national journals and meetings. He's got more than 50 articles published in international and national journals. Welcome, Dr. Ashish Nabha. I think Dr. Ashish was still attending an emergency case. He should join us anytime. And finally, Jennifer Wehmeyer. She is our Global Marketing Manager for Diagnostic Cardiology. Jennifer will be the moderator for today's session, and she can bring global perspectives during the discussion. She is an Irish native and is currently based out of Freiburg, Germany. Jennifer has a Bachelor of Nursing Studies and a Master's in Health Informatics and has been with GE in various applications training, sales, product management, and marketing roles for almost 20 years. Okay, turning on time to Jennifer. Over to you, Jennifer. And welcome all the panelists and thank you very much.
Thank you very much for the great introduction, and it's a delight to be here and to be with you. And I think that the questions that we have are very, very exciting. And it's really, really nice to talk about this topic ahead of World Heart Day, which I think is very important. And it's a very important day that people are aware of. So I'm going to start off with a question to all of the panelists, if I may. And this is a particularly passionate area of mine, but I would like to hear your input on why ECG is still considered important now that we have a lot of other and more advanced or perceived to be more advanced diagnostic techniques. So I'm not sure who'd like to start us off. Dr. Ulas, can I put you on the spot?
Okay, it's a privilege to be talking here. Thank you, Jennifer and Murthy and the entire team of GE. I think the way you have put it up, it's very great, and I think it suits to the World Heart Day celebrations. Thank you. And then I think the question which is like often asked, why at all ECG is so very important? Why it is still considered to be, one of the best of the investigative tools, at least in the initial stages of heart disorders assessment. It's like almost like 125 years and more since this electrocardiology science has come in, and clinical usage is definitely more than 100 years, and definitely much earlier than what Max 7 we are going to be presented with. I think there's a philosophical tone here, why a particular investigation tool could be tool is non-invasive. Number one, is the investigation tool is simple? Is the investigation tool is widely available? Is the skills involved in doing that particular test, is the investment is market? If you look at the ECG, none. It is simple, it is non-invasive, widely available. It is like one of the cheap or easily affordable kind of a investigation. So that is set. Now, any investigation which has all these qualities cannot be just like that used so very widely. So there has to be something more to it. Not just that it is easily available, everybody can do the ECG. A test, what is that information the test would provide the clinician? Ultimately, it is based on that too. What I believe here is the kind of information and to a great extent of accuracy ECG gives. About what? First of all, is there any heart disorder? For example, if you talk about kind of an impending attack, heart attack, or an ongoing attack, or a heart attack has occurred earlier, ECG can tell you. When there's a chest pain, and the first thing what we would do is to get an ECG before you do anything, before you can even take a detailed history. So the accuracy of heart attack, impending or occurring or occurred, all that. Second, the ECG can tell you, most importantly, the rhythm. Heart rate is slow, heart rate is fast, heart rate is regular, irregular. The heart rhythm is coming from an upper chamber, lower chamber, and how serious it is or whether you could even ignore. When it comes to the function, entire function of the heart, whether the heart is weak or it is as strong, dilated, hypertrophied or thickened, is there any fluid around it? So many things. Apart from just the heart problems, ECG could be kind of an accurate indicator of certain non-cardiac problems. Are there any effect of drugs on this patient? That could be reflected on ECG changes. Is there drug toxicity? Is there poisoning? What is the body temperature? Is it patient is severely exposed to severe cold? ECG could tell. Is there any kind of a neurological problem? The patient is comatose. the pressure in the cranium, pressure intracranial or inside the skull, is the pressure more? That could be reflected here. Hormonal changes, the impact of the drugs. I mean, I can go on and on and on. And then these could be seen on a simple test, which is non-invasive, which is affordable, and no much investment. And that is why ever since this has come into practice, it is growing in popularity. And now the advances, like for example, your Max 7, it's so great. So I think that the usage is going to increase only, rather than, there could be any test which could kind of even replace ECG.
Yeah, thank you. I think that's a really comprehensive answer. And it's great to hear somebody who's really so passionate about the ECG and the power of the ECG, and indeed what it can tell us even beyond the cardiac status. Dr. Pravir or Dr. Rahul, do you have anything to add on why you think the ECG has really stood the test of time?
I think I would agree to everything Dr. Ulhas has said, but I will only add that it's probably the quickest and the most simplest and the cheapest of the cardiac electrophysiological investigations, and all other more advanced form of investigations like a TMT or a Holter or an electrophysiological study only they add on to the information, the basic information you get on the ECG. Secondly, in a country like India, in the primary care, in many remote areas, probably this is the only cardiological tool available to detect some acute life-threatening conditions like an acute MI or a dangerous arrhythmia. And in fact, we frequently come across patients when they are referred to us after primary treatment, that in an acute MI, the patient has been already thrombolized in a peripheral setting. Or many a times nowadays, we also see a patient of supraventricular tachycardia having already received IV adenosine or diltiazem in a peripheral setting. And that's the probably beauty of the most simple form of investigation, that is that which we call ECG, which helps us in tackling so many life-threatening situations at very primitive settings also. So this is probably one of the very interesting and very encouraging things about ECG. And I think everything what we do after ECG is they only add to it, and probably ECG will always remain as an important diagnostic tool in the hands of physicians and cardiologists.
Yes, thank you very much. I think I absolutely agree that ECG gives a very, very clear and good direction and seems to be deployed as one of the first tools, definitely. Dr. Rahul, I think your colleagues have covered this topic very well, but do you have anything else to add on why you think ECG has maintained its relevance?
May I add to just that? What was said? I lost my connection in between. Sorry.
We can hear you quite well now.
Okay. So I have nothing more to add except to just demonstrate. I'm primarily a non-invasive cardiologist, and echocardiography is my passion. And at the non-invasive cardiology lab. But just to tell you the importance, we never do an echocardiogram without an ECG attached to the patient, and that remains a teaching to all our fellows. We never do an echo without an ECG attached, ECG. That's because even we have very sophisticated advancements happening in terms of 3D echocardiography, strain imaging. They're all linked to ECG triggered image capturing. So that is the power of ECG echocardiography even now. The other thing is we have been demonstrating wall motion abnormalities in the emergency settings for diagnosis of myocardial infarction very early on. But the definition of MI is based on ECG findings. ST elevation MI, non-ST elevation MI. Echo is still not part of the diagnostic triad that we call for myocardial infarction. So that speaks itself for the power of this very simple yet very effective investigation that cannot be, we cannot function in cardiology without ECG. It's as simple as that.
Yeah.
Thank you.
Yes, thank you very much. Thank you. And I was astounded to find out that really it has been 120 years since we've had the ECG at our disposal, and how it has truly stood the test of time. So I'm going to jump a little bit into look to the future, and I'm going to ask you, Dr. Ullas, what's your opinion on the current trends, and what do you think the future of the ECG machine might be like?
Well, I think Max 7 stands an example, like where every ECG machine has to be of that variety. I mean, I think in the present era, what we are looking at is transmission of the data. A ECG presently is taken there, and the technician or another healthcare worker has to bring in that ECG to the physician where he is sitting. Now, everything should be connected digitally. There's a wide penetration of the internet and the Wi-Fi services. So whatever that is being done at the bedside or wherever, the ECG, when that is taken, should be securely transmitted or sent across to the person who is involved in the care of the patient. I think that is what is going to be happening, which is, I think the Max 1 definitely has it, and we need to be having every ECG machine of that ability. Second, some of the qualities, however good the technician is, there are occasions where certain subtle displacement of the electrodes or some of the artifacts which may actually critically change the waveforms. So if there's an inbuilt safeguard to reduce the artifacts and to alert the technician to look at a particular electrode, that would be a great advantage. Now, miniaturization of ECG machine, which would definitely have to give all these 12 leads absolutely in the same standardized ECG, has to take place. Well, over a period of time, the ECG machines have become smaller. But I am looking at, for example, in some of the smaller clinics where the ECG machine is as small as possible. That is one. And then we have now tools which could be considered as a handheld ECG tools, which have been validated in several of the models, but they're not as accurate as the 12-lead ECGs are concerned. So we need to have a handheld ECGs, which definitely at this point in time cannot give you all the 12-lead ECG information, but then validation, as much validation as possible with respect to the 12-lead, so that every single smartphone becomes an ECG machine by itself. The smartphones are becoming smarter every day. It is just that a patient has the smartphone and maybe he touches once with his thumb on a particular spot on his mobile phone. Maybe he attaches that mobile phone, say for example, on his foot or on his leg, and then the smartphone collects it. So that is the future I'm looking at it. And the so-called artificial intelligence attached to that. For example, not only that you have the so-called ischemia pattern or infarction pattern, or hypertrophy pattern, or intervals, all that, but then that should have that inbuilt artificial intelligence which could alert the physician, the patient or the person to be reaching to the hospital in case if there is a really a requirement. We have now a technology which is developing even before the patient develops a chest pain. Even before the patient develops the chest pain, ECG is capable of identifying an impending heart attack. What a great, the science that could be. It is going to be non-invasive. After all the changes evolve and things to get reflected on an ECG or even in a blood test, it takes time. But what has been seen is the waveforms, the electrical activity of the heart is the first one to get affected when the heart attack is impending, much before the enzymes are released or much before the biochemical tests become wrong and much before the actually standard ECG patterns of ischemia or infarction evolve. So now we are talking about a smart mobile phone which acts like a standard ECG machine or less than that, but then it recognizes a serious condition as a myocardial infarction.
Mhm.
You know, there is a tremendous scope for the advancements, but what is so important here is, you know, we should all salute the Eindhoven. We have not gone any more beyond whatever he had put in. The same 12 leads, maybe initially it was 3 and a little more modification, but whatever the science, wherever the electrodes Eindhoven told and wherever we put it in, that science is so very rock solid. So maybe in the coming few years, we might be able to have little more number of electrodes or little, so that, you know, there will be what we call true global picture of the heart, right?
Yep.
These are some of the, you know, innovations which I'm expecting, and I think it is going to be possible very soon.
Yeah, thank you very much. I think it's exciting about how potentially ECG could be playing a much bigger part and outside the hospital as well. So Dr. Rahul, I'd like to ask you a follow-up question on that. Do you think that ECG machines will become like what we have today with some of the home blood-based sample collections? Patients are able to do their home glucose monitoring. They're able to monitor themselves at home. Do you think ECG machines will be taken home for recording and for interpretation?
Yes, very much. We are already there, and during COVID times, huge need of this kind of technology was felt. We had some vendors going door to door and doing home ECG for us. But like blood pressure instruments have evolved, and we have now home BP monitoring being demonstrated to be one of the best ways of picking up hypertension in patients. I think ECG is much more interpreter independent and subject independent, much more objective than a blood pressure machine. I think it is very much possible. I believe soon we should have that. Very much required.
Thank you very much.
People are already carrying their smartwatches and coming to us with their abnormal ECGs demonstrated by their smartwatches. So yes, there is a need of this.
Yeah, and do you think this is making people more aware, this ability to have ECGs on their smartwatch and to monitor this?
One of the reasons why mostly there have been false alarms for which people have consulted based on what the smartwatch told them. But it would be a wonderful tool to capture events in actual patients whom we expect to have rhythm disturbances and anticipate electrophysiology problems in time, and actionable evidences is generated right then and there, capture of an ECG. It is going to be very, very useful, no doubt.
Okay, thank you. And Dr. Pravir, your colleagues have mentioned lots of benefits to having ECG elsewhere or being able to miniaturize ECG. What do you think that your ideal ECG machine would be like, or what type of ECG technologies would you think would make up your ideal scenario?
Well, I would divide it into 2 types. One is for ECG for a dedicated cardiologist. I think a dedicated cardiologist just needs a good quality 12-lead ECG to interpret the findings. For others, say for a general physician or a primary in the primary care setting, I think besides good quality ECG, you need a good interpretative algorithm also, which of course Gs are already provided in form of 12SL, but a good interpretative option can help, particularly with the help of artificial intelligence, can help the primary care physician in making the diagnosis, giving the initial therapy, and then transporting the patient to specialist. Of course, in this context, a transmissible, easily transmissible ECG can help the patient more when the cardiologist can read the tracings and guide the primary care physician in that respect. So I think the future lies with a good quality ECG trace and good interpretative option, easily transmissible ECG, which everybody who receives it can read it properly.
Thank you very much. You made an excellent point about the different type of support needed depending on whether, of course, you're a specialist in the field or if it's a generalist. And this was a conversation that I've had with some of the customers that I visited lately, how not all the algorithms and not all the enhancements in ECG will benefit necessarily cardiology. It could be that they benefit patients who are being seen by other specialities and are maybe triggered to then attend cardiology. And that fits actually very nicely to the theme of World Heart Day, which is really about harnessing the power of digital health to improve awareness, prevention, and management of cardiovascular disease, because that's potentially picking up patients who were unknown or who didn't know that they had any type of cardiovascular disease. And I know from what we've seen and in the situation that we've been living in the last year, telehealth and the ability to work differently has become something that we've become a little bit more familiar with. And I've heard from the team, your local team, that some of the customers were perhaps a little bit slow to adopt digital or telehealth solutions in the Indian market before the COVID pandemic. I don't think in that respect the Indian market is anyway unique. I think this was a challenge that was seen globally. But do you think that what we've seen in terms of moves or steps forward in telehealth and digital ICU, digital ECG will be something that will change moving forward? Is this something that you think is there to stay? Dr. Pravir, I don't know what you think about that.
Yeah, my line got disconnected. Can you repeat your question?
I was wondering if you think that the enhancements that we've seen and the changes that we've seen in the way we're working now with respect to digital ECG, tele-ICU, telehealth, that was really largely driven by the pandemic, will be something that you think will stay in your practice, or something that you think that we will develop further moving forward?
Yeah.
I think it's quite ironic that we're talking about digital connectivity and telehealth at the moment when we seem to have some challenges in connectivity. So Dr. Pravir, can you hear us now?
Yeah, I can hear you, but my line is getting disconnected. Yeah, I think in future, as we are experiencing in the last 1.5 years or 2 years, a lot of consultations and with teleconsultations and ECG transmission on mobile phones and on emails. I think this is going to stay because, number one, we are always talking about second wave, third wave, fourth wave. We never know. We see what the situation in the US is. So many cases coming. You don't know. So can you hear me?
We can. Unfortunately, we seem to be challenged a little bit by technology.
Yeah. So I think this is going to stay, and further improvement in transmission capabilities with the help of artificial intelligence and all, good quality transmission of good quality ECGs are definitely going to help.
Yes. So I think what definitely is a learning for me is that we need good IT infrastructure if we really are going to continue to work digitally, and for teleconsultations and for telecardiology, that's definitely a big, strong part. Dr. Rahul, I don't know if you have anything to add on that. Unfortunately, we've lost Dr. Pravir.
We agree, we are on the same page. I think that COVID was a blessing in disguise in this sense that These things got expedited. Teleconsultations in our country became legal, and they became an accepted fact. We have been receiving ECGs on WhatsApp from the patients. We unfortunately have had to go to a clinic, get it done, and then send a picture to us on phone. And better would be like a ECG machine itself sending us images from one part of the hospital to the other, wherever we are, whether we are traveling, whether we are in our homes. We can immediately receive a good quality ECG from the bedside or from the patient on our devices, be it mobile phones, computers, laptops. So definitely that is the order of the day. Physically going around looking at ECG printed on paper, I think will be a matter of the past soon.
Yeah, and I heard this recently from a German cardiologist, and he said that he can save a lot of time now because he doesn't physically have to go around the hospital. So they've implemented an ECG system where everything is coming to his desktop. He's not got quality concerns, and we've heard that that's important. You really need a good quality ECG to know that you're making the best diagnosis possible, and he's saving the time. So I think that a lot of things have been learned. I'm not sure we would like to live a pandemic again to learn more, but we've definitely got some silver linings. We've mentioned as well the role of AI and how AI can help. And Dr. Ulas, I'd like to hear from you a little bit if you think that that could help with interpretation. Do you see any moves in AI making an impact in clinical medicine?
Right. So thank you again. So when it comes to telehealth, or when it comes to telemedicine, including artificial intelligence, it's not that it wasn't there before the pandemic. All these technologies were very much there before the pandemic. It was just that there was some kind of a hesitancy to embrace this. So amidst all the negativity of COVID, and there's one definite positive thing that has emerged is the existing technology, its worthiness, its usefulness, we have realized, and now we started embracing it more and more. And this technology or this methodology of providing care or getting the information, whatever we call as a new normal, it's going to be essential in the future, and it's going to be getting more and more. There are so many advantages of telemedicine and even artificial intelligence, etc. Now, let me tell you some flip side about the whole thing here. The telemedicine and the telehealth and the artificial intelligence are good as long as they are analyzed in a most scientific way, and ignored in the most scientific way. Now, what is happening with the telemedicine and the telehealth or artificial intelligence is everybody who could make use of this technology is able to send the information to the physician. And now the physician is at the risk of getting flooded with the digital information which comes to him. Now, there has to be kind of a filtering of what is good and what is bad. But what is considered as bad may not be actually bad, and most often what is considered as good maybe rarely could be bad. You see, we are at that stage now, which is actually abnormal, which is not abnormal. That is what is the crucial or vital point with respect to this digital health and telemedicine is concerned. As long as the patient is seen on the screen and he is being able to communicate with the patient, and there is an existing data of the patient on the physician's desk, preferably in a digital way, and then only there could be any kind of a useful information or useful services that could be provided. But if it is simply in the air or in the cloud, patient sends the data, the doctor receives the data, it is not going to be very useful. So now it's okay. There are learning steps here. The technology is existing. We are able to get the data. even in the absence of the patient being in the physician's clinic or in the office. It is all possible. But what is dangerous is, without a system to identify, is this truly the patient requires attention, or this is a false alert? We need to break this jinx. Till such time the technology is not there to give us accurately what exactly is happening to the patient, there can be harm to both the parties, to the physician and the person who is seeking the advice.
Yeah, and I think it's quite common, the discussion about the fear about data deluge, with more and more sources of ECG, patients collecting their own information. How are people supposed to sort through what's relevant, not relevant? And I've heard some of your peers talking about how their inboxes are filling up every day with ECGs sent in from patients, and trying to understand which are critical and need to be addressed and which are less critical. So hopefully the future in AI has some solutions for helping to manage and to sift through to understand what's critical.
And if I chip in one more point here.
Yes, please.
Available of this digital technology, I think many healthy persons are getting panicked because they are looking at their smartwatch or smartphones, and that smartphone is telling that the heart rate is low or a heart rate is high, which could be absolutely physiological, which probably is necessary for the person. So there is a huge danger when there are certain alarms which are provided by those wearable tools. So that the great deal of education is required for the person who is actually using them.
Yeah, a great reminder of the need to actually have the context and to have the education to interpret the results. So it's not a matter of just doing the test, it's also having the knowledge to interpret the results that you've achieved. Speaking a little bit about the data and what we're collecting, I'm going to shift gears a little bit for the last part of our discussion. So a lot of the typical cardiac services that would have been offered, unfortunately, were stopped due to the pandemic. But we are seeing a lot of places restarting with treadmill testing or with Holter. But do you think that there will be a shift in these areas? Do you think that the pause has made people reconsider the importance of these tests in the diagnostic pathway? Dr. Rahul, I'd like to hear your opinion on this.
Very rightly said. Definitely we are seeing in our center, for example, except for the peak 1 month of the pandemic, April of this year, we have been regularly doing all the non-invasive investigations for the patients. But the number of patients coming in was much less. So now, apparently there is this window period being perceived by the patient before the third wave comes in. And there is a huge rush of patients demanding themselves to get a complete health check or a cardiac check done. And that includes a treadmill test or a stress echocardiogram. It's like a surge we are seeing now, particularly in last month, and September has been chock-a-block for us. So yes, this is very rightly said. We have realized the value of getting ourselves evaluated, even though you may not be suffering from any disease. Good quality checks, which are known to be useful, need to be done in time. Patients who are deferring their tests have now realized the value of these investigations, and yes, they are coming up to us and getting themselves evaluated more openly now. Yes, they have realized the utility of medical systems, which was not so much realized before the pandemic.
Yeah, that's quite interesting. So people are almost preparing themselves and ensuring that they are in the best health should something happen. Okay, so a good focus on the importance of maintaining health. Dr. Pravir, I see that you have rejoined, and I'm not sure if we can hear you again. I was wondering if you've seen. No, I think I was too quick, and you seem to have lost your connection again. Dr. Ullas, have you seen the same as Dr. Rahul, or do you see a shift in the way that these tests are being done in your facility?
Well, I think I should agree with Dr. Rahul's observations. The same thing here. But I think there is still not very optimal therapies being provided to the patients. I think it would take long time from now to actually we being very justified in the way what we have been providing the therapy to the patients. For example, typically in ours is one of the exclusive cardiac care centers. What I see every day here is it takes more time to provide the same quality therapy to the patient as compared to the pre-pandemic days. There has to be a protocol. In fact, the physician societies themselves have laid upon this, and the government insists that there has to be certain protocols to be carried out before the patient gets into the main critical care area, because there's always a possibility that the patient may be harboring the infection. Mm-hmm. That is a big blow to the patient with the acute cardiac sickness, because, for example, myocardial infarction, every minute is a golden minute to maintain that cardiac function. So what could have happened from door to needle, what we call, even in the best of the centers, it has been extended more than 1 hour to their standard timing. This is a big hit. Some of the centers, including us, even our cardiologists, they are prepared, but not prepared to take up any patient and push, because there's a system existing. But there are not many hospitals which are geared up like this. Not before an RT-PCR done, not before any screening. You need to have a absolutely fantastic setup to receive the patient as the patient enters in. That is not feasible in most of the centers in the country. So we are able to provide, I think, better and better care, because we are also understanding that we need not have to be worried so much, because you follow those precaution steps. And most of the physicians in the country, I think, they are vaccinated, I think, optimally. Like 2 doses, which our government recommends, I think most of our physicians, I think, or on the healthcare workers associated, I think they are vaccinated. So the fear is less. That has actually tremendously affected, or increased the quality of the healthcare what we are providing to our patients. So we are coming back. Human nature is to fight all the odds and come back and then try to win over the nature. It is just that you do not kill the nature at one point, and that is why nature hits back to you. So anyway, I think we are learning. We are respecting the nature, and we are getting better and better.
Yeah. I think what you said is very familiar to me. I heard from many people that I've spoken to that it was very difficult to practice normal medicine during the acute phase, and that this has definitely changed. And I think it's very reassuring what Dr. Rahul said, that people are really taking their responsibility for their own health and making sure that they are being checked now. It's a shame that it takes something like this to drive people to do that, but I think definitely there is some silver lining. It's been a very, very interesting conversation. I'm really reassured to hear about how important ECG is. There was some great discussions about how it's important because it's quick, it's accessible for so many people, and it's so easy to do. And I think that there is a lot more that we can hope for in the future from ECG, and of course from AI. And there's exciting things happening in the area of AI, hopefully meaning that the inboxes of our physician friends are not all going to be stacked up with ECGs, that there's going to be some smart things there to help to manage the workload as well, and to make sure that we're getting the best out of the technologies. I would like to hand over to Murthy to see if we have any questions from our audience, and to say thank you very much to our panelists for a great discussion so far.
Oh, thank you, Jennifer. Thank you, doctors. Excellent discussion, very informative and enriching. And just for the audience, so you can see in the control panel, the chat window. Please share your questions in the chat window. So looks like we are here to get some questions. Some questions have come. That is on the Mac ECG machine. So I'll direct it to Jennifer because you have been part of sales of this machine already in Europe. This is does it provide vitals, and how Mac 7 can help in remote patient monitoring, and how Mac 7 can be used with e-bike or treadmill.
So Mac 7 is a dedicated 12-lead ECG machine. So it provides the 12-lead ECG, and it's designed for rest in ECG. So it's not designed to be used in a stress testing function. I think that was the answer.
I said asked vitals.
Yes,
So vitals, it will deliver heart rate and ECG, but if you're looking for more than that, it's not a vital signs monitor. So heart rate, ECG, and then the Marquette 12SL interpretation alongside that. And it will alert to critical values. So if it's being used in, for example, an emergency department, it can be programmed to alert to heart rates that are outside the limit, or to for example, to long QT, which I know has become very topical in many areas.
The part of the question was whether it could be a part of remote monitoring.
Okay, so it can be deployed outside of the hospital. It really could be deployed potentially anywhere. So as you saw in the video from Oswin, it's got a great trolley that makes it very mobile, but it's also not too big that it could be taken then and moved outside of the hospital. But we also have some other devices in our portfolio that are potentially a little bit more mobile. So we have the Mac 600, which I think Murthy and some of his local team can provide some more information about. That's a smaller form factor again, and is designed with a handle to make it very mobile.
Thanks, Jennifer. Thank you. So question to Dr. Rahul and then Ullas to get your perspective. Hospitals are talking about paperless, but still ECG thermal paper is seen everywhere. Is it practically feasible in our country to run a hospital completely paperless?
It's a very good question, very pertinent question. And this is a tussle that has been going on between us and IT in our hospital, at least for almost 5 years now. We went paperless. We were all hospital records, no files, no bedside paper on the patient. But then we realized we have to have a mix of both before we can really be completely paperless. But for something like ECG, I feel it is very much possible. We still are using thermal paper, yes. You know the drawbacks. I, for one, am aware of the storage space required for the stress test related ECG paper that I have to store for our lab on a day-to-day basis. So I will be very happy if this technology is there, and I think it is very much possible. Paperless is possible and should be the way forward.
Thanks, Dr. Rahul. So I'll go to the another question. So this I'll direct towards Dr. Ullas. So hospitals and diagnostic centers together generate huge amount of ECG data, which is not being digitally stored today. So what do you think the real challenge for storing the data, and what are ways you suggest for hospitals to store data digitally, which can help build AI algorithms?
See, the greatest challenge is the lack of the knowledge about the use of the data that could be stored digitally. We have not understood the importance and how it could be used for further clinical research and betterment of their healthcare. Those people who are really into it, well, they have been collecting the data. They are doing their job. So it is just that each diagnostic center could be connected with one of the physicians or several of the physicians, one of the hospitals or the several of the hospitals, and either the diagnostic center person or the hospital physician. If they are collaborating, well, the data is there. And there are, in a year, at least 1 or 2 papers we are publishing solely on the basis of the data that is stored, not necessarily in our hospital, anywhere else. And at least since 10 years, it is possible to have any one of the simple ECG machines to have the ECG traces, which could be stored in a PDF format. The one ECG machines what we have in our hospital and some of the diagnostic centers who are actually in touch with us, that is going on for a long time. So it is just that everybody should know that if they are interested in a clinical research, so much of the data that is simply being wasted, not being utilized. So I think I answered your question. And
Yes, sir. Yeah.
please tell me.
Yeah, you answered it. Thanks. So then next is question on the price of Max 7. So this program we utilize just to give you a glimpse of what Max 7 can does, but we have a detailed launch program, and we'll come to your places. We'll commercially launch this product to all of you, and then there are different combinations, so we can work on the prices, and then officially it will be announced. This was just an opportunity for us to showcase our brand, so we'll definitely revert back to you on this. Dr. Rahul, the question to you. Skill trained technicians, nurses is one of the challenges in healthcare. A digitized, seamless workflow can reduce the human errors. What level of digitization do you think the hospital should adapt in order to minimize the errors? I think there is a hold in Dr. Rahul's place. So his video has gone. So while he logs in, can I ask Dr. Ullas if you can take up this question again, sir?
Okay, we are talking about the level of the technical skills, what a technician should be having to obtain a good quality 12-lead ECG. Over a period of time, the technology has improved so much that it has boiled down to simply placing the electrodes at the right place. That is where the skill is required presently. You need to have a connection to a safe electrical port, and now you have cables neatly marked on them where the electrode needs to be placed. So with the way we are getting the ECG, I do not think imparting the skills to acquire a good quality ECG is a challenge. No more. That's my thinking. What needs to be done is the ECG technician has to be trained little more. For example, he should be more communicative with the physician. Should I do a standard 12 lead? Should I do some extended leads? Should I do some modified electrodes placing upper more? And is it inferior MI? Am I supposed to be taking one more ECG? I think this communication with the physician needs to be increased, I believe. That's probably is the only limitation what I'm seeing. Otherwise, I think any literate adult could do a standard 12-lead ECG.
Thank you, Chief.
Jennifer, you have something to add here?
Jennifer,
Yeah, I think that the training is super important. And what we definitely hear time and time again is that it's very difficult to interpretate an ECG of poor quality, and that it is very important that things such as correct lead placement is taken into account. Limb lead reversal, incorrect positioning of chest leads not positioned correctly, particularly on women, are things that we do hear common challenges with. So definitely training, it definitely can't be done by an unskilled operator. And training is a big part of doing a correct ECG.
Thanks, Jennifer. I think we got Dr. Rahul back on the audio.
Yes, and I could not listen to the question.
Yes, sir. So we'll come to you. So this question comes under trends in technology. It's slightly out of ECG range. So it's on talking about NIBP. The deadly duo of diabetes and hypertension is the biggest challenge here in India, being the diabetic world capital. What's the role of ambulatory BP test for the diabetes patients? How helpful it will be in the treatment?
I'm very glad that this question has been asked, because I'm in charge of the non-invasive lab and look after ambulatory BP monitoring. We have steadily seen the demand for ambulatory BP monitoring go up from consultants, and we have had to purchase extra ambulatory BP monitors to meet the demand. Because of the realization and incorporation in the guidelines that confirmation of hypertension, something as simple as hypertension, ideally should be based on an ambulatory BP monitor. And so there are very interesting findings that are coming up. People with nocturnal blood pressure, people with paradoxical rise in the nighttime blood pressures. So not only diabetics, this is very, very important for any person whom we suspect to have hypertension. So ambulatory BP monitoring is definitely the way forward, the appropriate way to diagnose hypertension accurately, because once diagnosed hypertensive, you're likely to be hypertensive all your life. So it has to be properly diagnosed, and ABPM is the best way in our country because home BP monitoring requires much more effort. A patient has to be trained, and we don't have that kind of level and availability of infrastructure for training the patients for measuring home blood pressure accurately. The ambulatory BP monitoring is definitely the best way to diagnose hypertension, to confirm the presence of hypertension, to diagnose some types of hypertension like white coat and reverse white coat hypertension, which cannot otherwise be diagnosed by any other means. So not only for diabetics, for everybody, it is a very useful technique, yes.
Thank you, sir. So the way when we do a lot of survey in terms of developing products in the future, where we came across with a lot of people, talking about we need the ECGs in the form of Telegram, WhatsApp help. This can help cardiologists to get ECG and convey the interpretation. However, these apps lack clarity and the track of previous ECGs, which create huge confusion. How do you handle this kind of situation in your day-to-day practice? Do you think there is a need for development of simple app exclusively for digital ECGs reporting from the mobile or tab? So I'll direct this to Dr. Ullas and then come to Dr. Rahul. I think Dr. Ashish Nabar is also now connected. I think after this prolonged case, he's been able to join. Thank you, Dr. Ashish. I think Jennifer can ask some of the questions we missed in that. We have still 12 minutes to go. And before that, question to Dr. Ullas on this WhatsApp, Telegram, and digital ECG reporting from mobile and tab.
So you have been asking me that the relevance of having the previous records of the ECG of a patient.
Yes, sir.
I think without this digital technology, it is very difficult to have it in one place. And reading the ECG is much more worthwhile, much more useful if that is compared with the previous ECGs if they are available. And we always insist a person who has been in a follow-up, what was his ECG in the past? It gives you so much of an information about how the rhythm is behaving now as compared to the previous one, whether the heart became more enlarged, or is there any chamber which is becoming much more enlarged, whether pressure, whether it's a systemic pressure or a lung pressure is increasing, decreasing. Many things. And for example, if you have done a particular procedure to make a QRS morphology narrow or wide, how was it before and how was it after? If you would like to compare the previous ECGs, present day technology is not helping you. So there has to be something, maybe it could be even in the ECG machine itself, where the data is stored so that you put in the patient's details. It itself will start showing you when was the last admission, how was the ECG in the past. And I think the technology is required in this context.
Thank you, Dr. Ullas. So over to you, Jennifer, for your questions to Dr. Ashish Nabar.
All right, good. So it is a great opportunity.
Yeah, just a second. Sorry. Yeah, please go ahead, sir.
Yeah, actually, I was thinking to end by 8 o'clock. I gave some appointments here. Now, it had been wonderful, Murthy, Jennifer, Dr. Rahul, everybody in the GE team. I should say it was my privilege, and it's a wonderful way of celebrating World Heart Day. And I wish you all the best. And then your Max 7 is really impressive. That's how the technology is going to be forward. I'm sorry that I'm prematurely going away, but then best wishes to all of you. Thank you.
Thank you so much. Thank you so much, Dr. Ullas. You have been
Thank you, Dr. Ullas. Take care.
Yeah, thank you so much. Yeah, Dr. Ashish, can you hear us? If you can go on unmute.
Hello, are you able to hear me?
Yes, sir. We can hear and we can see you.
Okay.
Just out of
Yeah. My
case.
excuses, Jennifer, coming in late. I was held up in the cath lab, and then some outpatient clinic to finish. Yeah, let's discuss something in the remaining time.
Yes, thank you very much for joining, and no problem at all. I think if any audience understands the fact that patients have to come first, it's definitely this one. So thank you so much for jumping in. One of the questions that I really was looking forward to asking you, and I'm hoping that you'll be able to answer, is what do you think about wearables and patients coming to you with the data from the wearables? Do you think it's making them more aware? Is it providing you with useful information, or is it increasing your workload?
No, I think wearables is something that we will have to incorporate more and more in our clinical practice because many things. I mean, in the COVID pandemic, I think we have had more of these situations where sometimes the patients are not able to come to the clinic firstly. So you have to still, sometimes they are in the old age homes or sometimes they're not mobile. So these group of patients will need something like a wearable. The arrhythmias by nature are paroxysmal. So your office ECG or a limited 24-hour Holter or a 48-hour Holter or even a 7-day external loop recorder may not help. And therefore, if you have a wearable ECG recorder, which, for example, the watches, then it is possible that they can be worn for as long as they can be, and the patients can indicate whenever they had symptoms. So not only is the recording possible, but also symptom to the recording correlation possible. So that's one more help of having the wearables. But this all variable data is not necessarily analyzable by the physician. I mean, it's a huge volume of data, and that's where the AI will come in play. I think AI is a deep neural. They have deep neural protocols, self-learning protocols, where the machine, instead of being fed a particular paradigm, learns by itself to diagnose arrhythmias, and somebody can override that at the end of it. But this is what will reduce the work burden of a physician and probably bring out information with which the physician even may not be able to handle or diagnose. I mean, some of the difficulty is that the physicians are not comfortable with AI because they don't know what logic the AI uses to come to a conclusion. But as the AI grows, it will become indispensable that we not only have the wearables, that we have the AI to work with this data, and that in some situations, like for example, the mountaineers or people working in shifts, they may have some rhythm problems. Now, how do you put ECGs, or how do you monitor rhythm disturbances in them? So a wearable would actually help in a big way. And the biggest reason to have a wearable is atrial fibrillation, of course. With the availability of NOACs, with the ease of prescribing oral anticoagulation, we have a huge opportunity to prevent stroke and atrial fibrillation. As all the people attending here know, 1/5 of the times the cause of stroke is atrial fibrillation. So even atrial fibrillation should be actively sought after in people who have had stroke. So you may need wearables in such patients, and even people who are predisposed to a stroke or are going to benefit from anticoagulation, like a high CHAT score. So I think wearables have a big role in diagnosing atrial fibrillation, in seeing if sudden cardiac death can be predicted and things like that.
Okay, thank you. Yeah, I think what you said makes a lot of sense. Sorry, Murthy, I think I...
Thanks.
Yeah, no. So you can go ahead.
Okay. And I just want to follow up on one thing you mentioned. So you mentioned a lot of patients not being able to attend during the pandemic and
Yes.
having to do some more telemedicine. And this was a topic that we discussed as well. Do you think that some of what happened to facilitate patients' consultations during the acute phase of the pandemic will stay? Do you see telemedicine becoming more a part of your everyday job?
Yeah, absolutely. I think thankfully at this point in time, we are a little in a comfortable zone with the pandemic, and the patients want to come and see us. The in-person evaluation, of course, has a big advantage. But in absence of that, if you have variables giving you the standard parameters, the oxygen saturation, the pulse rate, the blood pressure, and if you can carefully listen to the history even on tele, at least the old patients who are supposed to be following up with you can be reasonably handled, can be reasonably managed. And I mean, this is there in this sort of telemedicine is of course there in people like us who deal with implantable devices, the pacemakers and ICDs and CRTs. The remote monitoring is although the adaptability of that is a little slow in India, but remote monitoring is already in place. So I think as electrophysiologists and as cardiologists, we are used to the tele. Of course, it can get sometimes difficult with new patients whom you do not already know. That might be a little concern, but even new patients in emergency situations, it is better to have that teleconsult than delay the consult, say because of the time to reach emergency medical room or something like that. I think it's
Okay.
there to stay.
Yeah, makes a lot of sense, and I think it definitely has the potential to improve practice and get
Yes,
patients the help they need quicker. Yeah, thank you.
yes.
Murthy, they were the two questions that I had that were really pressing. So thank you very much. I'm delighted
Thank
that you joined, that we got to
thank
have
Yeah,
that
we
discussion.
did
pleasure.
not miss anything. Thanks, Dr. Ashish, and thanks for bringing those
Thank you.
questions, Jennifer. So before we conclude this session, any message for the audience on the occasion of World Heart Day, Dr. Rahul, and that will be followed by Dr. Ashish.
Interesting, taking a World Heart Day a day before. I'm a big, I should say, follower of meditation practice. And I take this opportunity to highlight the role of meditation as an established cardiovascular risk reduction strategy. So my message would be to incorporate meditation into our daily schedule and reap the benefits that it has to offer for our overall health and well-being, apart from being an accepted measure of reducing CVD risk from the American Heart Association.
Thank you, Dr. Ashish.
Yeah, sure. I think I am interested that the sudden cardiac arrest awareness, yeah, this is more in our country. uh, we really don't have much happening in terms of being able to to do something for people who have a witnessed sudden cardiac arrest. And we would be only able to do things if our masses realize that sudden cardiac arrest, one is able to do something. There is a good Samaritan law which does not get you in trouble just because you tried to help a patient who or a person who has had a sudden cardiac arrest. And the hands only CPR, that has made things quite simple, at least, or doable, till you can get a defibrillator, which of course is again a difficult step in our country. But a CPR, hands only CPR, should be learnt by kind of every adult. Everybody who can vote in our country should understand, should learn, and should be able to do a CPR and provide some possibility to the person, to the victim of sudden cardiac arrest. And in Mumbai, we have this organization called iCare, which in the COVID time did a lot of training modules virtually. The sudden cardiac arrest week, which is starting on from today. Again, there is a lot happening under the aegis of this iCare and Indian Heart Rhythm Society, trying to make it a mass movement. Just like chest pain should be followed by a ECG, similarly, a sudden cardiac arrest should be followed by a CPR. So I think this is something that we need to take to the masses. Thank you.
Yes, thank you. I think that's very, very powerful and absolutely bystander CPR is something that should be
Yeah.
advocated.
Yes.
Delighted to hear that there's a program. Murthy, I think we lost your connection shortly. I'm not sure if you can hear us.
No, can you hear me, Jennifer?
Yeah, we can hear you very well now. Thank you.
Yeah, so thank you very much. Thank you so much, Dr. Rahul, Dr. Ashish, Dr. Ullas had to just disconnect and we lost connection with Dr. Praveer. But wonderful discussion. It was a great, very informative, enriching, and it definitely gave us a lot of information during this panel discussion. I would like to take this opportunity to thank the panelists, eminent panelists and the moderator. I would like to take this opportunity to thank Abhilash, Arpita, Sridhar from marketing team, Paul and his team, all our regional managers, product managers, sales managers, channel partners, Genwork team members to bring us all together. Good night and happy weekend. Thank you so much.
Thank you.